this the right one?
Assalamualaikum Apu.
কেমন আছেন? Hi Megan.
Hi Megan.
Hi. Sorry, it's a different ID today. I didn't realize, and I was initially waiting for the
That's
other one.
I was also confused. I was about to knock you.
Yeah.
So hopefully everyone figures it out. I didn't realize Josh had changed it. So it's his first time sending it. So I think he maybe didn't realize it's usually always the same one. Just checking the poster that it's got the same. Hopefully. Yeah, okay. All good. Nice to see you, Tasneem.
Igualmente.
Igualmente.
Sí.
I'm not sure how many people we will have, but I suppose it does help that I'm on the right Zoom now. That might improve the chances. Oh, you got you. So, and we did share the video, Roshan, in Bangla. But you can have as much time as you want, Roshan, because we don't have a case. So we'll just do discussion after your presentation. So take your time. Hi, everyone. Welcome. Dr. Chandra, Dr. Pranab, Amana. Hi, everyone. Hi, Anne. Sorry, I told you the wrong ID. I didn't know it was a new one either.
That's okay.
I think the next course I was thinking to start on April 22nd, just so everyone's aware. I'll send an email shortly. Before that, we'll do, we've got HIV AIDS in March, and then neonatal palliative care has been requested a number of times. So we'll do that in April. Okay, we have a few more people joining just now, so let's let them join and then I'll introduce Roshan. Great, so I think I'll get started. This is one of our mentoring sessions, so welcome to all. So many of you have joined various palliative care courses that we've run, and when we continue to have these sessions. So we're very pleased to have you join us. We have a couple sessions like this over the next few months, and then we'll do another course just for your information. So today's session is on family-centered care, which is, I think, very helpful for all of us. And Roshan will give us a presentation on the subject. And also she has prepared a video on the same topic. So, and that's in Bangla. So it's really a helpful tool for you. And you remember, you can always use these videos to share with your colleagues. And if you want to have the video that you can download, because you cannot download from the YouTube, then just message myself and we'll send you the link to a version that you can download. So I want to introduce Roshan, who is a nurse and a nursing instructor and is joining us from Dhaka. I've known Roshan for a very long time, and so I'm really pleased that she can be with us. And she's a research mentor and, like I said, a nursing instructor. She has a master's in public health and in nursing sciences, and she's currently at Shahid Tajuddin Ahmed Nursing College in Gazipur. So thank you, Roshan, and over to you.
Thank you, Megan, for your nice introduction. Just let me start my screen. Yeah. Sorry. Is it visible? Audible, is it?
Yeah, it's perfect.
Okay, thank you so much. Yeah, thank you, Megan, and everybody, and very welcome to our presentations. Today, we're going to talk about palliative care, providing family-centered care. So from these sessions, we hope we can able to learn about family-centered care, benefits of family-centered care, social needs of patients and family facing with life-limiting illness, and how to provide emotional and spiritual support to patients and family conference as well. So first, family-centered care. As we are human beings, we living with family. So family has a tremendous role in our life throughout the life. Family plays an integral part, providing care to the patients in acute conditions, even chronic illness with life-limiting illness as well. So we have to recognize or acknowledgement of the family contribution to the patient's care. Family caregiver, also known as the informal caregivers, they are the unpaid family members, close friends and neighbors who provide assistance with our daily life activities and patients caring, like bathing, dressing, feeding, taking medications, wound care, or any other care as well. They also contribute to the coordination between healthcare providers and patients. And they also provide the financial support for the patients. And so family-centered care, according to Institute for Patients and Family-Centered Care, they gave a definition, says the mutual beneficial partnership between healthcare providers like doctor, nurse, other social workers, and any other healthcare providers and the family and patients as well in healthcare planning, implementations, and evaluation. So these are the definition of family-centered care in palliative care perspective. So there are lots of benefits in family-centered care. Few are mentioned here. For the family-centered care, in palliative care, we can avoid a narrow view of problem belonging to just one person's problem. It means when a patient is suffering a problem or critically ill patient, ill disease, it is not only his or her problem, it's also whole family problem. So with this approach, we also can consider how to patient's illness impact upon the entire family and social system and community as well. With this, we can recognize the interconnectedness as well, as patient's illness impact upon the patient's family and community and society as well. On the other hand, community and families' reaction to the illness of their patients also can affect. So with this approach, we can minimize some of these problems. So we will discuss regarding the aspects of palliative care. Everybody know what are the aspects or component or element of the family care, palliative care. So if we know the what are the component or aspects of palliative care, then we can give the total care of patients. The components are physical aspects, psychological aspects, social aspects, emotional aspects, and spiritual aspects. So today we'll discuss or focus on social, emotional, and spiritual issues. So what are the social aspects of palliative care? Social aspects of palliative care, we recognize or focus on the patient's, him or herself. We are not focusing only the disease. So in this approach, we can give a patient's physical, social, emotional, spiritual issues. Sometimes they have some overlapping or influence each other, but all the issues are there with the life-limiting patients. So it is important to consider how can we support the whole family rather than just one patient, as patient is a part of a family, part of community, part of that culture or that system. So we have to focus the total family or entire family to provide the palliative care. There is an example. This is collected from the palliative care toolkit. It is a Bangla version, and so here we have some foreign faculty. That's why I'm trying to translate this one. There is a young lady living in the slum, and her husband passed away 6 months ago with suffering of HIV/AIDS. She gradually becomes sick, weight reducing, mentally unstable, and she is anxious. After her death, what will be happen with her kids? She has a bad wound in her leg. She can't sleep due to pain due to pain in the leg for her bad wound, and she is in bedridden, and her parents living so far, so she can't take care of her children or kids, and she is very much anxious about her kids. Her house owner came to her for rent, but after her husband, she doesn't have any income source. So even in her neighbor believe or says to her, she is taking punishment from the God, and gradually she also believe this one. So she wants some support from others, but no one still give her support. In this situation, if we can imagine the scenario of that lady, we can realize the scenario of our family as well. Her illness is the one problem, but other problems, she is anxious about her kids after her die. What will be happen? Who will take care? What will be their educations, and what will be their income source? everything she is suffering. So if we want to give patients total care or comprehensive care, we have to think the total scenario of these patients and total even his or her family. So if we want to give up patients social care, we have to understand the relationship or role of family, role of that patients in the family, and bonding of the family members. So depend on the assessment of that patients and family, we can offer her or his many many aspects of care, like she may need financial support or educational support, housing, nutrition, or daily life activities. So it depends on the patient's condition and family supports and resources of that family or patient's surroundings. So when we will provide the social care, we have to consider if possible, we can refer to the patient to their home so they can live with the family members, and she will be comfort, or family also will be comfort in the family, in the comfort, sorry, they will comfort the provide comfortable care in the family. So if possible, we can refer to the family, and we can offer to telephonic service or home service as well. And we can also involve the other social worker or any community involvement, other NGOs person, for providing additional support of that family or that patients. So how can we provide the emotional support? It is very much important to consider the emotional support of a patient, those who are suffering in the terminally ill patient, like as physical support. So when we give a patient physical care, like pain management or any other management, then we also consider his or her emotional, psychological, social, or other needs also. It is not only the adult patients' need, it's also true for the children or pediatric patients. So we should consider this one. And emotional care often not included in our pre-service educations. When we have studied our nursing diploma or graduations or MBBS, that time emotional issues not focusing such much, or in the professional training also not mentioned as needed. But in the palliative care, it is very much important. We have to focus this one to provide a comprehensive care or entire or holistic care to the patients. So when providing a palliative care, we need to understand the emotional issues and how can affect the people like patients and family, and how they suffer with these issues, and how they are daily life passing. So we should consider this one, and then we have to minimize these issues. So in human being, emotions are well developed and play a very important role in our life. So recognizing that our emotions are linked with our survival as human being, it developed according to our age and surroundings, language, and experiences. So emotion can be changed and shaped based on our experiences and our surrounding supports as well. It is unique and individual. So we will focus on it. Feelings are our conscious awareness of emotions and then name as we give to them. There is an reflection activities here. We can imagine everybody, those who are attending in this sessions, we all can imagine a scenario that you have just been told that you have a life-limiting illness. So this situation, how will be your immediate feelings? You can write in the chat box as well, or in your notebook, or you can thought also. What will be your immediate feelings if you heard that you having a life-limiting illness or life-threatening illness? It is not curable. What will be your immediate feelings? And what will be your immediate thoughts? You can think this one as well. What would you need to do next? What would you wish to spend in your remaining life or rest of life? Where would you like to die? There are 5 questions here based on your imagination. You can think and write in the chat box. If you know you having a life-limiting illness, what will be your immediate feelings, thoughts? What would you need to do next? How would you wish to spend in your rest of life? And where would you like to die? Or if you want to unmute yourselves, you can share this one. Anyone?
There are lots of good comments in the chat. People are sharing how they would feel. Scared, worried, uncertain, disbelief.
Yeah.
And then people have shared that they would want to spend time with their family.
Exactly. Very good. Yeah. So when a patient are diagnosed with the seriously ill, what emotional reaction might be we have seen in our practical experiences? It may shock, disbelief, or denial. It can be fear and anxiety, can be sadness or depression, anger, envy, or acceptance. It is not sequential, can be happen to someone or cannot be. So this type of feelings or activities can be happen to the people when they are aware they have certainly life-limiting disease or life-threatening illness. They have only few days in their life, so maybe this type of reaction they may face. There is an example of Ali Banat. We know his history. He is suffering cancer, and finally how he managed his life and how he accept his disease as a gift from the God. It is an inspiration for our patients to counseling them. So how we show the emotions? Emotions are generated in our bodies in different way. We can express emotions by our behavior, by our facial expressions, with speech and languages, and sometimes we can use body gesture postures. So with this type of expressions, we show our emotions by our body. And emotions always linking with the communications. Sometimes when patients and family are expressing their thoughts, feelings, and sadness, sufferings, that time you simply say, don't worry, everything will be okay. But it is not meaningful to the patient. That doesn't go the feelings from the patients or sufferers. feelings can make physically more sick, like someone if suffering from fear or anxiety, it may worsen his or her pain, breathlessness, like this. So putting word to emotions open helps people, and so we have to encourage the patients and sufferer to express their emotions. It will make them relax and feel free. Behavior can show emotions without people having to talk. So some people may love to talk to express their feelings, some are not. They are may crying or showing any other activities to express their emotion. So effective communication, how can improve or improve the quality of life. There are some skills. So before going to skills, I am going to talk about the effective communication. What is it? It is a two-way process in which patients and family are informed about the nature of their disease, treatment, and prognosis, and also encouraged to express their anxieties and emotions. So it is a two-way process. So some are skills mentions here. Previously, we have learned from the communication skills, breaking bad news sessions, and some other sessions. We have learned a lot regarding the communication skills. Just overview here. Communication skills. We have to have active listener. We can showing our we can nodding our heads, and sometimes we can express yes, ha, and then that means we are with the patients, we are listening them, so so they can feel yeah, healthcare providers or she or he is listening to me. They will be encouraged to express their feelings. And we have to be with patients. It's not only the physical, mentally we also, and we also with the patient, we have to also patients, and when need, then we only respond them. Otherwise, no need to interrupt during conversation with the patients. And when they are asking something, we have to talk or give the correct answer. If any misunderstanding from others colleague, we should correcting them and make them understand clearly, and check their understanding level as well. So we also need to identify and evaluate the problem solving solution with the family and patient as well. Otherwise, we cannot solve their problem if we are not involving the family. So we also can offer a recommendation and plan with the patients and family. So so for the emotional care, we all healthcare providers in all level provide basic emotional support. For the special case, we have to refer to the specialist. Otherwise, basic support we can give by us. And we also need to build a supportive and trusting relationship with the patients and family. Otherwise, they are not willing to share their fears, worries, and feelings to us. So we have to have a trusting relationship with the patients to minimize their worries and anxieties. And simply listen and observe. We can do this one, just nothing to do with this patient, just stay with the patient and touch, empathetic touch the patient, actively listen and observe. Non-verbal issues can observe. And finally, we can encourage to release their emotions in word and actions, like crying, physical activities, or any other way what he or she wants. An emotional response can be variety, so we don't do any judgment, and we don't any comparison. We don't do any comparison with other patients as well. So how can we help the family member to provide emotional care to the patients? We can teach the family member. It is very much important and to teach family member so they can support their emotional support to the family members and emotional support to the patients at home and in the healthcare settings as well. So there are key suggestions to give the family members teaching. We can tell them to take a break from their usual task and just sit and talk with the patients. Ask the patient their feelings, their emotions, their stories, or what they are thought. And if they wish, they can read book, listen to music, or recite the Holy Quran, Bible, or as according to their religious issues, or express and give them opportunity to express their feelings, etc. So in this way, family member also can give the emotional support to the patients as well. So as a healthcare provider, we can teach the family member this one. So do not stop the process of emotional release by offering false reassurance. Previously, I have mentioned that sometimes we just tell to the patient, don't worry, everything will be all right. But it is not the correct way. It should avoid. And with this, we can stop the process of emotional release for the patient. So for patient and family member, if they are going to talk their emotional issues, we just will stay and active listening and give them support if needed. Otherwise, no need to give extra on false assurance to them. So encourage them to think about how their emotional have changed after other measured activities. Also, we can teach them or suggest them previously how they adjust and cope with this type of situation, so they can utilize this approach as well. So now we are going to talk about the spiritual aspects of palliative care. When patients are very serious or seriously critically ill, they often are looking for meaning and need spiritual support of that patients. So they are, and so that time we also can offer them spiritual support by reading, reciting the holy books as their beliefs, and we can offer them music and suggest to do meditation, prayers, and arrange spiritual leaders to visit the patients and family if they desire. So such type of activity can do to give the spiritual care of those patients for the end of life care patient or critically ill patients. So how can we provide the support for family caregivers? We can give them information about the illness, type of care needed. If patients go home, that time how can they will take care of patients, how they will change the positions or give medications, changing, posturing, and some patients have the ostomy, colostomy, tracheostomy. So how can they will take care of this ostomy? Some patients have the wound and oral sore. So we can minimize by the educations of the family members. So we can give them clear instructions how can take care, and when they will communicate with the healthcare providers. If needed, they also can communicate over phone, or some family member can come hospitals to know the update and give the follow-up. So with this type of support, we can give caregiver, and what will be the next planning when patient is in terminal stage, end of life, what can be happen and what will be the response. It also we can give education to the family member. So for the educations we can give, we can do the family conference. It is very much effective in the palliative care settings. So family conference is a tool and central role and give information about the patients and family, and also can understand the family's situations and scenario by the healthcare providers. So there are 3 phases of family conference. One is preparatory phase. Before conference, there are some preparations we will discuss later, and after that family conference sessions and final follow-up and implementation sessions. So what will be happen in the preparation phase? Before conference, we have the preparation phase. In preparation phase, we should consensus of among team means doctor, nurse, and other healthcare providers, can team member, and we can invite the patients with family member. We can ask the family patients who will be in the meeting. So according to patient's wish, we can invite and ask permission to the patients and clearly clarify the purpose of the meeting. So before conference, we can do this type of preparation, and during conference, we should give the introductions. So healthcare providers give their introduction. Who are they by name, positions, and what will be the benefit of this conference, or family meeting. We can state this one, and then we will talk and make them understand, and according to their understanding level have to talk. And if any reaction, questions, or silence they have during conference or talking, communication skills, we have to allow this one. And finally, we should facilitate them to consensus or make decision what should be done for these patients in future. And when we have completed the conference, we should implement the decisions what we made during conference and follow up as needed. And of course, documentation is very much important for the conferences. So finally, social support. Social support as a human being, part of family and community. So social support is important, and it is a partnership between the healthcare providers and family members. We should find out the problems of that patient and families and provide the care accordingly, and ask or seeking the other supports from the community and other organization as well. So emotional support, for emotional support, we have to build relationship with the patients and family, and offer them to share their emotions as needed. And communication and family conference are very much important to support the families. So for this, I want to conclude the sessions. If you have any questions or anything, you can share. Thank you very much.
Thank you very much, Roshan. We have some time now for discussion and comments.
There are some, yeah.
Dr. Pranab, do you want to say your comment, the last one that you wrote?
Which one?
Dr. Pranab was mentioning about caregiver training for paid and unpaid caregivers. It's like a really big need. Yeah, go ahead, Dr. Pranab. Please share your thoughts.
Thank you very much, Roshan, and you for organizing this relevant topic. Actually, palliative care, domain of palliative care extends to family. Without family, only patient is not the central whole. So this caregiver is unidentified. Caregivers are unidentified, unrecognized by the society sometimes. I feel so. So they are to be trained. The palliative aid nursing training should be organized, and that's why the perfect caregiving will be possible. Perfect means well organized caregiving is possible, fully possible. Thank you very much, Megan and Dawson. Thank you.
Thank you so much for your comments and suggestion. Exactly. In Bangladesh, palliative care center has this type of course, not exactly course, the system. When family members come to hospitals with the patients, they tell all the patients' attendance get a training, 1 or 2 days training regarding care. It includes the theoretical care and a demonstration as well. How they will take care, how they will take care of their patients in home after discharge from the hospitals. It is one type, and sorry, you wanna? Paramji?
Yeah, actually, I am involved in one NGO in Jharkhand tribal area, Koshis the hospice. There, 6 months training is going on for the tribal girls and boys. This palliative care, palliative aid nursing for 6 months course, and they are trained. They are trained in applying and even catheterization or blood pressure making, measuring, and all these things. So this is a required system to be trained, and so that palliative care, the value of palliative care will be enhanced. So far, I have experienced in this, and I go to Jharkhand near Bokaro for training them in palliative care, and I am a faculty of that NGO. Okay.
Excellent, nice to know. Yeah, as I sharing the experience, this one type of training for the family caregiver, and another training also established here, palliative care assistant training. It's also 6 month care, maybe 12 course. 12 course already completed. So some of
very
them,
good,
some of them completed the SSC, and or above SSC, but they are not other trained in professionals, but they are only palliative care training.
Very
6
good.
months, yes, they are doing the home care services for the patients.
Hats up to you. Yeah.
Home care. Yes. Thank you.
Yeah. Actually, this is the empowerment, and they get employment, isn't it? They get employment also.
Exactly. Yeah. They're doing job as well. Yeah. Thank you.
Thank you very much. Thank you.
Megan, over to you. Any more comments or?
Yeah, there are some more comments. I'll read out a few. Amna has said about financial concerns, and how do the palliative care programs in Bangladesh support the patients financially? Do you want to say some of the supports that the patients can get when they're in palliative care programs? Roshan?
Yeah, Megan, some patients got financial support, not for the family, only for the treatment purpose. If hospital admitted and they need some medications and investigations purpose, that time they provide the support, but not from the hospitals. Actually, it is the Palliative Care Society of Bangladesh has some fund. So from this fund, palliative, they supporting the family. And there are another maybe project. Those patients are died. Their family, remaining family, like young children and sister, brother, younger sister, brother, they have rehabilitation facilities from that project. So this type of support, financial support provided by the palliative care in Bangladesh by the Center for Palliative Care. But other support also, I know the like fundraising by the community volunteer and provide local support to them. Like, if you know any more, you can share, Megan.
Maybe I'll just ask Tasneem to comment on like the services, or Mohammed Pias, for the people living in the Cox's Bazar region, the host population and the refugees. If the patient's under palliative care, what supports are given to help the family?
Yes, carry on. I will join.
I have some other experiences. Some patient expired in the hospital, but they don't have the financial source to bring the dead body to home. That time, yeah, palliative care raised some fund and support the family to bring the dead body and do some religious activities after their death. It also happened in there.
Yeah, and the cost of the medicines is
Exactly.
sometimes
Sometimes.
covered. Yeah.
And at the initial stage, I have seen from some other NGOs support the food support, food package to the family, and morphine also provided. So this type of support given to the family and patients by the Palliative Care Society and Palliative Care Center in Bangladesh. As I know.
Yeah, and in the Coral Slum project, then they receive food package, festival gifts, blankets, and medicine is covered for certain medicines, for the palliative care medications that they need, the essential medicines. So,
ma'am, could I listen this question on English?
sorry, say that again.
Thank you.
Sorry, do you want to repeat, Dr. Mohammed? We didn't hear your full comment. You can say in Bangla too if you want.
Yes,
Okay.
repeat করেন, আমি আছি.
Okay. So basically, when we get this like that patient in refugee camp or host, first of all, the patient guardian or especially patient husband or wife in Bangladesh segment, basically if a patient get sick, husband take care or wife take care, not other person. Majority percent that happens. Okay. So when a patient become or diagnosed like that, this case cancer, stroke, or any like that, or severe RTA, this time the guardian feels so nervous or emotionally sick, how they manage or how they do, or why he or she just diagnosed this type of cancer, where what something wrong. They are so emotional sick, mentally sick. In this case, in our palliative team, especially in doctor, there are doctor, nurses, physiotherapist, palliative care assistant, and like that. Whole team, we stay in a hospital around, or sometimes we try to move the family house. And when we go to family house, there, especially first of all, our doctor just we, especially as a nurse, I deliver the whole data to our doctor and whole team. Then doctor just talk some things like that, why he affected or diagnosed, then he just reply or repeat this whole data that is similar to me or not. Okay, then according to diagnosed as a nurse and palliative care assistant and others, we talk to the patient guardian, especially who is the can capable to take this decision or are comfort to listen our talks or things or we want to share with the patient guardian. Then step by step we talk the patient guardian, and in some cases just we try to understand the patient guardian. Basically, please, it's on kind of things we have to die one day, but he's diagnosed right now, so don't worry, and right now we can do something. So especially sequentially, just as a doctor, as a nurse and palliative care assistant, just talk them and just try to mental and support. But in some cases medication is different thing, but especially we just to try to motivate them from our segment to strong or encourage them as they are palliative care thing. So it's about from my segment. So I hope that ma'am it will explain better.
Thank you, Piers. It was like what you were doing, you tried to explain, and it was good, I would say. For me, I will say in Rohingya camp, we had both blessings and bindings, because it's not exactly like our national one. We have had support for burying and dead body disposal. This one we already have very organized inside the Rohingya camp. And also for patient follow-up, we have had the system with both Rohingya volunteer and Bangladeshi BPCS, palliative care assistants. So it was like helping them for follow-up to come, even taking the notes when they want us to be here. It could be during dressing or bedding or other things they want us to do, especially from the caregiver's end. We tried. And particularly with Amna Ansari's question about the grief support. At first I will tell about grief. When you lose something or you are having a sense that I will lose this, that's the sense comes immediately to your mind, is called grief. So what worked better for us? Initially, we started people motivating with less talk. Just speak up if you want to talk. If you don't want, I will come later so that we can have a conversation. At least patient can express what he or she is feeling. Second one, motivating people about what they like to do. You know, people having different hobbies, even with works also. Some people might like cooking, some might like dancing, some will tell you that I just want you to come here and we can have a talk. That's it. So we follow different techniques to come up with solution for this grief support, not only for patient, but also the person who is helping the patient, I mean the family caregiver. And for our team, it was end of the day, those who work with me, they were allowed to speak up what they are willing to do, what their feelings, because you have to share with someone. That's it. That's how we were doing. I hope things are getting much better now, inshallah. Thank you.
Thank you so much for sharing that.
Thank you, Amna, for your questions. I think a majority of places where we do bereavement or grief support for after the patient has died, it's visits or it's telephone calls of some kind, right? Like either it's your team can have a program where after a certain amount of time, whatever is the traditional amount of time for that culture, that you call the family, you say, we're thinking of you, we're remembering your loved one, how is he doing? How are you guys doing? Or you can do the same with visit or multiple visits, like Tasneem is saying. So I think those things are really effective, we found, in many situations, but adapting them and being flexible to what the people need and expect and want, like Tasneem is saying, like if it's talking, if it's visits, if it's some other hobby that they have that they can resume. So. Any other comments or questions? We have had really good discussion. Thank you. For the PCA program at Bangabandhu Sheikh Mujib Medical University, Roshan, do you know if people are interested in that program? How do they, can they just talk to Lila about joining if anyone wants to refer people who want to train?
Next page. Yeah, I will.
Okay.
I'll confirm. Yeah.
Okay, so if anyone is interested more in what's happening at PG Hospital at BSMMU, then please just write to Lila. We can share her contact information, because remember, there are courses for doctors, courses for nurses, and then the courses for the PCAs, training for PCAs as well. So if this is an area now you're starting to think that you're more interested, then maybe that's a good thing to do, is do more training in person, see the center at BSMMU, etc. Okay, perfect. So I think maybe we can go for final summary from Tasneem in Bangla, please.
Sure, Megan. It was a very comprehensive one. I'm not sure I can finish it by 5 minutes, but I will try. সবাইকে স্বাগতম। বাংলা অনুবাদ করছি আমি। আজকের ফ্যামিলি সেন্টার্ড প্যালিয়েটিভ কেয়ার অথবা পরিবার কেন্দ্রিক প্যালিয়েটিভ কেয়ার সেবা কিভাবে দেওয়া হয় সেই বিষয়ে আজকে আমরা শিখেছি রসনাপার কাছ থেকে। আজকের শেখা থেকে আমরা জানতে পেরেছি যে ফ্যামিলি সেন্টার্ড কেয়ার আসলে কাকে বলে, কিভাবে এটা থেকে আপনি এবং পরিবার উপকৃত হচ্ছে, এটার সামাজিক প্রয়োজনীয়তা কি কি রয়েছে, এবং কিভাবে আমরা আবেগগত অথবা আত্মিক সেবাগুলো প্রদান করতে পারি। এবং আরো একটা টুলস নিয়ে আজকে আলোচনা করা হয়েছে, সেটার নাম ছিল ফ্যামিলি কনফারেন্স। আমরা যখন ফ্যামিলি সেন্টার্ড কেয়ার বা পরিবার কেন্দ্রিক প্যালিয়েটিভ কেয়ার সেবা নিয়ে কথা বলি, এটাকে ইন্টিগ্রাল একটা রোল বলা হচ্ছে, যেটা ছাড়া প্যালিয়েটিভ কেয়ার দেওয়াটা সম্পন্ন হচ্ছে না। ইন্টিগ্রাল মানে হচ্ছে যেটা ছাড়া পুরোপুরি হচ্ছে না এই ব্যাপারটা। এবং আমাদের এখন সময়ের সাথে সাথে এই জিনিসটাকে রিকগনাইজ করা, এটাকে একটা স্বীকৃতি দেওয়া যেটার প্রয়োজনীয়তা রয়েছে। এবং ফ্যামিলি কেয়ার গিভার বলতে কাকে বোঝানো হচ্ছে? ফ্যামিলি কেয়ার গিভার হচ্ছে সেই লোকটি, সোজা বাংলায় বললে, যিনি পরিবারের লোকের সেবা করে থাকেন, যেটার জন্য তিনি কোনো ধরনের আর্থিক সহায়তা পান না, তিনি হচ্ছেন ফ্যামিলি কেয়ার গিভার। ফ্যামিলি সেন্টার্ড কেয়ার যদি আমরা দেই পরিবার কেন্দ্রিক সেবার ক্ষেত্রে, আমরা কি কি ধরনের উপকারিতা পেতে পারি? প্রথমটা হচ্ছে এটা আমাদের যে সমস্যাগুলো আছে সেগুলোকে কমিয়ে আনে। কারণ আমরা যখন একজন লোকের উপর একটা বোঝা দেই, সেটা থেকে যখন আমরা শেয়ার করে নেই আসলে কি চলছে, কে কোন পার্টটি করতে পারেন, সেক্ষেত্রে এটি কমে আসে। এবং রোগীর যে অসুস্থতা, এটা তার পরিবারকে এবং আমাদের সামাজিকতাকে কিভাবে ব্যাহত করছে এই বিষয়ে আমরা কথা বলতে পারি। এইখানে অনেকগুলো পার্টের ভিতর একটা ছিল সোশ্যাল কেয়ার বা সামাজিক সেবা প্রদান। সেক্ষেত্রে আপনাকে খেয়াল করতে হবে যেন রোগী এবং রোগী হচ্ছেন তার অসুস্থতার চাইতে অনেক বেশি জরুরি। আমরা শুধুমাত্র রোগটার দিকে তাকাই, রোগীর দিকে চিন্তা করি না। রোগীর দিকে চিন্তা করতে গেলে আমাদেরকে ফোকাস করতে হবে ফিজিক্যাল বা শারীরিক, সোশ্যাল, সামাজিক, ইমোশনাল, আবেগগত এবং স্পিরিচুয়াল, আত্মিক সমস্যাগুলোর দিকে। এগুলো অনেক সময় একটার সাথে আরেকটা ওভারল্যাপ করে যেতে পারে। আপনার কাছে মনে হতে পারে যে একটার দ্বারা আরেকটা প্রভাবিত হচ্ছে, যেটা আসলেই সত্য। এবং আমরা পুরো পরিবারকে এই ব্যাপারগুলোতে কিভাবে সহায়তা দিতে পারি এই বিষয়ে আমরা আজকে শিখেছি। আমরা সোশ্যাল কেয়ার দেওয়ার ক্ষেত্রে কনটেক্সট একটা জরুরি বিষয়। পরিবারের সম্পর্কগুলো, এই পরিবারে কে কে রয়েছেন, কালচারটা কিরকম, এই কমিউনিটিতে কি ধরনের নর্মস ফলো করা হয়, কি ধরনের আচার, রুচিবোধ, এই ধরনের জিনিসগুলো আমাদেরকে জানতে হয়। আমরা আরো জানতে হয় যে রোগীর আর্থিক অবস্থা কি চলছে, এই বাড়িতে পড়াশোনা করার মতো কেউ রয়েছে কিনা, এডুকেশনের ব্যাপারে বলা হয়েছে। ঘর বা গৃহস্থালী, আমাদেরকে যে উদাহরণটা দেওয়া হয়েছিল সেটাতে আমরা দেখেছি যে বস্তিতে থাকেন একজন, সুতরাং সেই ব্যাপারগুলো। নিউট্রিশন, তারা খাবারের কি ধরনের সহায়তা পাচ্ছে, আমাদের এখানে কোনো কমিউনিটি আছে কিনা যারা সাহায্য করতে পারে এদেরকে আর্থিক, সামাজিক অথবা মানসিক কোনো দিক থেকে। এবং দৈনিক চলাফেরার জন্য তার আসলে কোনো সহায়তার প্রয়োজন রয়েছে কিনা। আমরা সোশ্যাল কেয়ার গুলো যখন দেই, চেষ্টা করতে হবে এটা যেন বাড়িতে দেওয়া যায় ইফ পসিবল। আর তাহলে তাদের কি হবে, তাদের পরিবারটা তাদের সাথে থাকবে। এবং আরো একটা ব্যাপার আমরা খেয়াল করতে পারি, এই পরিবারে যে শিশুগুলো রয়েছে তাদের খেলাধুলা অথবা তাদের শিক্ষা সংস্থানের জন্য কোনো ব্যবস্থা আমরা করতে পারি কিনা। কারণ পিতামাতা অসুস্থ থাকলে দেখা যায় যে তাদের দিকে খেয়াল করার কেউ থাকে না। আমরা কোনো একটা কমিউনিটি অর্গানাইজেশনের সাথে তাদেরকে ট্যাগ করে দিতে পারি যাতে তারা এই সেবাগুলো পায়। এরপর আমরা ইমোশনাল বা আবেগগত সেবার কথা বলেছি। আমরা অনেকেই ভাবি যে আবেগগত সেবা শুধুমাত্র বড়দের প্রয়োজন হয়, না এটা সত্য না, এটা অ্যাডাল্ট এবং ছোট দুজনের জন্যই প্রয়োজন। ইমোশনাল কেয়ারটাকে আমাদের শিক্ষা ব্যবস্থায় অথবা আমাদের মেডিকেল ব্যবস্থায় খুব বেশি ইনক্লুড করা না হলেও এটার প্রয়োজনীয়তা এখন বোঝা যাচ্ছে। আমরা একজন মানুষের আবেগের সাথে বুঝতে পারি সে কিরকম করে আপনার প্রতি তার আবেগের প্রতিফলনটি ঘটায়, অথবা সে যে পরিস্থিতির ভিতর দিয়ে যাচ্ছে সেটাকে সে কিভাবে নিয়ন্ত্রণ করে। এরপর আমরা শিখেছি রিফ্লেকশন অ্যাক্টিভিটি সম্পর্কে একটা বলা হয়েছে। আপনি যদি কল্পনা করেন যে আপনাকে এই মুহূর্তে বলা হলো আপনি কোনো দুরারোগ্য ব্যাধিতে আক্রান্ত হয়েছেন যেটি আর কখনোই ঠিক হবে না, ইমিডিয়েট ফিলিংস সম্পর্কে জিজ্ঞাসা করা হয়েছে। আপনার হঠাৎ করে মাথায় কি চিন্তা আসবে সেটা, আপনি এখন কি করতে চান, এবং আপনি আপনার বাকি জীবনটা কিভাবে কাটাতে চান, এবং আপনি কিভাবে মারা যেতে চান, এই বা কোথায় মারা যেতে চান, এই প্রশ্নগুলো আমাদেরকে করা হয়েছে। আমরা বেশ কিছু উত্তর পেয়েছি। এক একজনের রিয়াকশনটা এক এক রকম হয়ে থাকে। এখানে শক, বিশ্বাস না করা, ভয় পাওয়া অথবা দুশ্চিন্তাগ্রস্ত হওয়া, প্রচন্ড রকমের ভীত হওয়া বা দুঃখ কষ্ট পাওয়া, রাগ দেখানো, শত্রু সুলভ আচরণ করা অথবা খুব স্বাভাবিকভাবে মেনে নেওয়া, এগুলো মানুষের রিয়াকশন হতে পারে। আমরা কিভাবে ইমোশন দেখাই সেটা আমাদের ব্যবহারগত হতে পারে, আমাদের ফেসিয়াল এক্সপ্রেশন, চেহারা বদলে যাওয়া, ভুরু কোচকে যাওয়া, হেসে দেওয়া, এরকম হতে পারে। আমরা অনেক সময় নিজেকে গুটিয়ে নেই, লোনলি অথবা আইসোলেটেড, অথবা আমাকে সবাই ছেড়ে গেছে, এরকম একটা অনুভূতি মানুষ প্রকাশ করে। এবং বডি পোশ্চারে দেখা যায় ক্লিনচড ফিস্ট, মনে করেন হাতের মুষ্টিবদ্ধ করা অথবা হাত পা শক্ত হয়ে যাওয়া, এরকম একটা রিঅ্যাকশনও আসতে পারে। আমরা চেষ্টা করব তাদের যে কথাগুলো আছে সেগুলো শোনার, এবং আমরা কখনোই বলবো না যে এটা ঠিক হয়ে যাবে, এই ধরনের কথাবার্তা আমরা বলবো না। সময়ের সাথে মানুষ অনেক কিছু মানিয়ে নিতে পারে এবং এটা সময়ের সাথে সাথে খারাপও হতে পারে, এমনকি ওর্স হতে পারে, সেটা আমরা বলবো। আমরা মানুষের সাথে এমন ভাবে কথা বলবো যেন তারা এনকারেজ ফিল করে যে সে যে আমার সাথে কথাটা শেয়ার করছে আমি সেটা শুনছি কিনা। কারণ আমি একজনকে বলতে বললাম, তারপর আমি এর কথাটা শুনলাম না, অথবা কথাটা শোনার পরে আমার সাথে আর কারো কথা বলতে ইচ্ছে হচ্ছে না, এরকম ব্যাপারগুলো হতে পারে। আপনি যদি জানা থাকে যে কি কি ধরনের রিঅ্যাকশন রোগী দিবেন, সেক্ষেত্রে আপনি এই ইফেক্টিভ কমিউনিকেশন বা দ্বিমুখী যে প্রক্রিয়াটা কথাবার্তা বলার, এটাকে আপনি চালিয়ে নিতে পারবেন। এবং আমরা খুবই এনকারেজ করি রোগী যদি কোনো রিঅ্যাকশন দেখায় এটা আসলে অস্বাভাবিক কিছু নয়, সুতরাং এটাকে আমরা এনকারেজ করি। আপা জানিয়েছেন ইফেক্টিভ কমিউনিকেশন স্কিলে কি কি আসে। প্রথমটা অ্যাক্টিভ লিসেনিং, বিং প্রেজেন্ট উইথ পেশেন্ট, আমরা রোগীর সাথে আছি এবং যখন প্রয়োজন হবে আমরা তখন কথা বলবো, কাউকে কথার মাঝখানে থামিয়ে দিব না অথবা তার কথা শুনছি না এই ধরনের কোনো আচরণ আমরা করব না, এবং সঠিক উত্তরটা দিব। যদি কোনো ধরনের মিসকনসেপশন অথবা মিসআন্ডারস্ট্যান্ডিং থেকে থাকে আমরা এটা কথা বলে ক্লিয়ার করার চেষ্টা করব। আমরা ইমোশনাল কেয়ার গুলো যখন দিব আমরা বেসিক ইমোশনাল সাপোর্ট দেওয়ার চেষ্টা করব, একটা ট্রাস্ট ওর দিশে আমাকে বিশ্বাস করে এরকম একটা সম্পর্ক গড়ে তোলার চেষ্টা করব। আমরা শুনবো এবং অবলোকন করব, অবজার্ভ করব যে রোগী কি করছে, রোগীর আচরণগুলো কোন দিকে যাচ্ছে। আর এক্ষেত্রে আমি আগেও বলেছি ইমোশনাল আচরণগুলো মানুষ থেকে মানুষে ভিন্নতর হতে পারে। আর আমরা যখন ফ্যামিলি মেম্বারকে একটা ইমোশনাল কেয়ার দিতে যাব আমরা চেষ্টা করব তারা একটা কাজ করছেন, অনেকেই বলেন আমি কাজ করছি আপনি কথা বলেন, ব্যাপারটা এরকম না। আমরা তাদেরকে ব্রেক দিয়ে তারপর বসে কথা বলার চেষ্টা করব। আমরা রোগীর জীবন সম্পর্কে জানতে চাইবো। কোনো রোগীর ক্ষেত্রে বই পড়ে শোনানো, গল্প শোনানো অথবা শুধুমাত্র কথা বলা বা তার কথা শোনা এগুলো অনেক ভালো কাজে দেয়। আর রোগীকে জানাবেন যে আপনি যে কোনো কিছুই করতে পারেন, আপনার যদি এখন কান্না পায় আপনি কাঁদতে পারেন, আপনার যেটা মনে হচ্ছে আপনি আমাকে বলে ফেলতে পারেন। আমরা স্পিরিচুয়াল বা আত্মিক সেবা নিয়ে কথা বলেছি। যখন একজন রোগী খুব গুরুতর অসুস্থ তখন সে জীবনের মানে খোঁজে অথবা আত্মিক কিছু করার চেষ্টা করে। আপা বাইবেল অথবা কোরআনের কথা বলেছেন। আমাদের অনেক রোগী কিন্তু বলেন যে কেউ পড়ে শোনালে ভালো লাগতো, কেউ আমার জন্য খতম দিলে ভালো লাগতো। এই ব্যাপারগুলো আমাদের দেশে খুবই কমন। আর আমরা কেয়ার গিভারকে সাপোর্ট দেওয়ার ক্ষেত্রে এই দিকগুলোতে আরো একটা ব্যাপার করব যে জীবনের শেষ সপ্তাহগুলোতে কি আশা করা যেতে পারে, কি ঘটতে পারে এই রোগীর সাথে। আরো একটা টুলস এর কথা বলা হয়েছে যেটা দিয়ে আমি শেষ করব, সেটা হচ্ছে ফ্যামিলি কনফারেন্স। আমরা অনেক ধরনের টুলস ব্যবহার করি, ফ্যামিলি কনফারেন্স টুলসটা নিয়ে বলা হয়েছে যে এটা রোগীর লোকের সাথে আপনার একটা বৈঠকের মতো। এইটার 3টা ফেজের কথা বলা হয়েছে। এটা শুরু করার আগে একটা ফেজ থাকে, আর একটা শব্দ ব্যবহার করা হয়েছে এখানটায় কনসেনসাস, যেটার অর্থ হচ্ছে একটা জেনারেল এগ্রিমেন্ট। জানা থাকা কে কে থাকবেন, আপনাদের পক্ষ থেকে কে কে থাকবেন এবং পরবর্তীতে ফলো আপের ধরনগুলো কিরকম হবে, কে কোন রোলটি এখানটায় করছেন, আপনাদের গোল কি এবং তাদের কাছ থেকে তাদের রিয়াকশন শুনতে চাওয়া, কোনো প্রশ্ন থাকলে প্রশ্নের উত্তর দেওয়া। আমার এইটুকুই বলার ছিল। অসংখ্য ধন্যবাদ।
Thank you, Tasneem. That sounded very detailed. So I really appreciate
I
it.
tried, Megan. Thank you.
Excellent. Okay, so we'll wrap up there for today. So we'll have our next session in 3 weeks, and that one is on HIV care and addressing myths about HIV and learning a bit about HIV from Dr. Catherine, who will be back next month. So thank you very much, everyone, and have a safe week. We'll see you in a few weeks. Thank you. Good night, everyone. Thank you, Roshan, especially for excellent presentation again.
Thank you so much.